Here we're talking about intraosseous placements. Here we're going to talk about intraosseous placements or IOs, and these can be placed by physicians and whatever your institution's policies are, sometimes trauma nurses, medics, etc. And the location is typically going to be your distal femur, maybe the proximal humerus, the tibia is a common spot, as well as the distal and proximal portions. The sternum is not a location that we recommend placing this for obvious reasons. Now, you're going to place this whenever time is of the essence, whenever you're having a difficult time accessing this patient's blood vessels. Maybe you've failed 2 times, they're appearing shocky, and so you need access. Specifically in shock and burn scenarios where you have circulatory collapse, if you have an obese patient or really edematous and just difficult vein access. Now, contraindications to intraosseous placement is going to be a fracture at the bone side, relative infection is going to be a relative contraindication, inability to identify the bony landmarks, or if you've had an IO attempt in that specific area within the last 48 hours. Obviously, these are not going to be MRI compatible. And if you have a patient with like osteogenesis imperfecta, this is not going to be the best option for this patient either. Now, the locations typically, I like to start with the tibia, the proximal portion. So for our pediatric patients, we're going to be going just medial to the leg. So I stay away from the fibula. I don't tell fibs. So I'm staying medial and just distal to the patella. So 1 to 2 centimeters medially and 1 to 3 centimeters below the patella. On the distal portion of the tibia, we're staying again on that medial aspect, and we're just a few centimeters above the medial malleolus. The distal femur, you're going to stay again on the medial aspect of the fibula. You'll go 1 centimeter proximal to the patella and 1 centimeter medial. And you can secure that leg as it's outstretched. Typically, I'm going to be reaching for this blue intraosseous needle. The pink one is really too small for most pediatric patients. I don't even really use it on neonates that often. So the blue is really to go to for most patients. This yellow one may be used for obese patients. So whenever you're placing this in the patient's skin, you can push down that needle through the skin, and you have to see at least one black bar. If you cannot, if you're all the way to the skin, you need to go up a size. So you go through the skin, and we'll show you how to place this IO. So pick that size, make sure that you have the one line visible. You're going to go at 90 degrees at the location that you've chosen, and then you're going to put pressure and drill into the bone. Now, whenever the bone gives way and you feel that resistance stop, then you'll stop drilling. You'll pull the gun off, and you will unscrew the IO portion, and then you'll instill some IV fluids or like NS. Make sure that you don't have extravasation in the tissue around or behind the bone, and then you'll secure it and use that IO. Now, if the patient is awake and they have pain while flushing, you can actually give something like 2% lidocaine. Typically, we're given a 0.5 milligram per kilo up to about a 40 milligrams max. Now, you can give and push fluids through this. You're going to have a lot more pressure than just a regular IV. So you're going to need to use pressure bags to administer fluids in a timely manner through this. And you can give almost any other medication that you can give in a regular IV. You just aren't going to give things like chemo medications. Now, you can also draw labs off of this, but you may not be able to run all of your labs depending on your laboratory setup. Medications, as mentioned, you'll give the same dose, rate, and concentration, and you're going to use those higher pressures. Now, whenever you're finished with the intraosseous needle, you can actually remove it by putting on a syringe and twisting in a clockwise manner as you're pulling out, and that will be able to just pull directly out, put a Band-Aid over, and you are good. The patient's good to go. Make sure you do this before the patient goes into MRI and things like that. Let's talk about shock. So we have to be cognizant of whenever our patients are on that spectrum of shock and wherever they may have SIRS type symptoms, so that's systemic inflammatory response syndrome. And these patients are going to be having elevated temperature or leukocytosis. So those temperature is either going to be elevated, greater than 38.5, or depressed, lower than 36 degrees Celsius, and then leukocytosis or abandemia on their white count. You'll also have some other things. It could either be tachycardic or bradycardic and some respiratory distress like tachypnea or if they're intubated. Now, sepsis is that serves patient with suspected or proven infection. Severe sepsis is whenever we have dysfunction of our organ systems, like our cardiac or acute respiratory distress syndrome, or more than two or more organ dysfunctions, like your liver, you see increase of LFTs, your kidney function, decreased urine output, etc. And septic shock is whenever he has dysfunction despite fluid resuscitation. So you're getting this inadequate tissue perfusion, you're getting a worsening lactic acidosis, hypoxia. This patient is in significant danger of dying or really bad morbidity if you do not turn this around very quickly. Now, vital signs are important to know based on your pediatric patient's age. So, for adults, for pulse rate over 100, we're concerned, but that's not the same for pediatric patients. So, have your little reference guides, know what the normal blood pressure, normal heart rate, respiratory rate, vital signs for your patient is, and reference those. So whenever we're looking at shock, we want to recognize it quickly. We're trying to get the oxygen delivered from the lungs to the tissue, as well as glucose administered to the tissue, and removing those toxic metabolites and getting that cleared out of the system as well. So things that we can do, we can improve the patient's oxygenation. We can place them on oxygen. We can actually improve their cardiac output. We can increase that by giving them fluids. We can also place them on blood pressures. And then we also want to treat the causes of shock. If this patient is septic, we want to put them on some antibiotics. If this is a neurogenic shock from like a brain injury, put them on pressors. And we're going to monitor this patient closely to look for any kind of decline or monitor their improvement and see if we can wean them down off the pressors. So do you need to add things like pressors? Do you need to give them more fluids? Do they need to be intubated to take off some of the metabolic demand that this patient has? There's a lot of different ways that we can help our patients get through this sepsis and shock state. Now, some things we want to also look at is what type of fluids, what type of antibiotics, what kind of pressors we're going to put this patient on. Access, as we talked about earlier, is something really important to cover. Try to review your pediatric algorithms and follow those as you go along. Now, different shock medications, fluids, you may consider giving something like Plasma-Lyte, lactated ringer, or normal saline. Plasma-Lyte or LR, probably your preference. Antibiotics is going to be dependent on your age and likely condition. You may be covering gram-positive or negative organisms. Pressors, do you need to start them on something like epinephrine for patients that have like anaphylaxis, or norepinephrine, so because you have some vasodilation, so you get some of that constriction, or things like dopamine. And then reminders, we do our dosing in volume when we're talking about fluids, so milliliters per kilo. For our medications and specifically antibiotics, we're doing milligrams per kilo. And then things like our pressors, we're going to be starting on micrograms per kilo per minute. And you're going to titrate these based off of the patient's condition and their clinical history. Do they have heart problems? We may not give them as much fluids initially. And then antibiotic choice may be dependent on what is the most likely bug for this patient. A neonate just born, we may consider GBS as a highly likely organism that we need to treat. So as we mentioned, fluids are important. We usually will give a balanced crystalloid or something like lactated ringer so that we can reduce the hyperchloremic metabolic acidosis that we see like in normal saline. And we talked about the fluid bolus is typically volume per kilo, so 20 milliliters per kilo on children. And we give that as quickly as possible, especially in our kiddos that are in septic shock. You're not just going to put it on the pump over an hour. You're going to give that in 5 to 15 minutes. And you're going to evaluate for fluid overload. Maybe they have a heart dysfunction and they're overwhelming the heart, and you start seeing respiratory distress because that fluid's going into the lungs. You need to be aware of that patient's clinical change and condition. try to make sure you are familiar with how to drop these medications and how to administer them. All right, let's talk about different medications to give in shock. So you have things like pressors, where you're going to be cognizant of your alpha adrenergic and your beta adrenergic effects, and also the route of medication being given. Is this a code-like scenario where you're going to be giving push doses of that medication, or are they not coding, but they need that constant vasopressor support. So you can put them on a drip. Usually we're doing that in micrograms per kilo per minute. And you can titrate that up and down. And do they sometimes need both of these, a little bit of a push and that drip to kind of get them stabilized? Antibiotics are going to be clinically dependent based off of the context. Is this a neonate that may have something like HSV or E. coli or GBS? Well, it may start them on something like ampicillin with gentamicin or acyclovir. Or if they're a little older, maybe move to something like Rocephin. In your immunosuppressed patients, you're going to consider covering for Pseudomonas or MRSA, giving things like cefepime or vancomycin. If this is a toxin-related issue where you have a staph scalded skin syndrome, maybe you're going to start them on vancomycin, but also halt the um, protein production by throwing on some clindamycin for this patient. When performing a lumbar puncture in a pediatric patient, there's a few differences from adults. You can still set up in generally the same way, but you also need some skilled helpers who can hold your patient still while you're performing this. Another benefit for pediatric patients is that their anatomy is so much smaller, so usually you can kind of fill the landmarks quite well on the spinous processes. You're still going to be going between that L3, L4 mark, finding that patient's iliac crest and dropping down. And before you start this, you'll go through the consent procedure with the patient's family if the patient is a minor, and getting consent, and then performing this procedure in a sterile fashion as we've done previously. Whenever you have that sterile procedure all ready, you'll also have the mask on your holder, and then kind of enter through that L3, L4 to obtain CSF fluid. Once you've obtained that, then you can send the labs off, getting your gram stain, your protein, your cell count, sending off for culture, and any other labs that you may think would be helpful looking for this patient. Then you'll write your procedure note and kind of wait. Hopefully, some of those lab results come back quickly so you can see if you have any indications of a bacterial or viral infection on your patient.